So I'd like to introduce Alina Grylls, who has completed a diploma in nutritional therapy at CNELM and BSc bridging modules at CNELM in order to gain access to the master's program. Her final MSc dissertation was awarded a distinction and was published in the Biomedicine and Pharmacotherapy journal. Alina is due to start her PhD at Exeter University, further exploring the link between microbiota and hypertension. So today, Alina's presentation is on the link between microbiota and hypertension, with a focus on the LPS-TLR4 pathway in endothelial dysfunction and vascular inflammation, and therapeutic implication of probiotics. So Alina, welcome. Hello.
Thank you so much for having me and letting me be part of this conference and letting me present the findings from my MSc dissertation that, as Indrani mentioned, was published. I'll share my screen. All right, so another paper on microbiota, which basically shows how relevant this topic is in current research. The focus of this research in terms of population was on prehypertensive and hypertensive adults, and the chosen intervention was probiotics. The two main mechanisms identified were endothelial dysfunction, as defined by nitric oxide impairment, and vascular inflammation, both of which were induced by lipopolysaccharides. The most relevant variable looked at in human studies was blood pressure. Similarly to my colleagues, I have chosen a mechanism review, and to sum it up, it is a narrative review based on the systematic search of the literature. This type of methodology helps to isolate specific components of underlying pathophysiological mechanisms, which present an opportunity for a more robust generation of candidate interventions. The aim of this research was to examine the effect of lipopolysaccharides and probiotics on the pathophysiology of hypertension. The objectives were to perform a systematic search of the literature on the link between microbiota and hypertension, with a further focus on lipopolysaccharide-induced endothelial dysfunction and vascular inflammation, and to perform a narrative analysis, critically evaluating the evidence for the impact of lipopolysaccharides and probiotics on vascular activation, as well as its relevance in clinical hypertension. So hypertension presents, as we know, a significant public health challenge. It is a well-recognized key risk factor in cardiovascular disease, in chronic kidney disease, cognitive dysfunction, and dementia. Nearly a third of population is affected, and amongst over 60 years of age, the prevalence reaches 50%. It is estimated that over 1.5 billion people will be hypertensive by 2025. And this is due to projected rise in life expectancy, but also the prevalence of contributing risk factors such as poor diet, stress, and sedentary lifestyle. The cause of hypertension is clearly identifiable in only 5% of patients. Despite new treatments and lifestyle changes, a third of hypertensive patients have treatment-resistant hypertension. It is that even with a minimum of 3 prescribed medications, the normal blood pressure is still not attained. So in light of these statistics, understanding of underlying pathophysiological mechanisms is extremely important. And as we've just heard, microbiota can be described as an endocrine organ. It is now well recognized that it regulates many pathophysiological processes, including maintenance of intestinal barrier integrity. Identification of a healthy microbiota, though, is quite difficult due to high interpersonal differences. But in general, it is characterized by a high diversity and richness. Some exogenous and endogenous factors can alter its composition and lead to dysbiosis. Interestingly, the risk factors for dysbiosis and hypertension are somehow similar. That includes age, stress, obesity, and indeed the microbial diversity and richness in hypertensive individuals is far poorer than in normotensive controls. So one possible mechanism involves the translocation of lipopolysaccharides due to reduced integrity of intestinal barrier. Lipopolysaccharides, as we just heard from my colleague before, are toll-like receptor agonists, and thus able to activate vascular endothelium and trigger several downstream signaling processes, which include induction of reactive oxygen species, pro-inflammatory cytokines, and adhesion molecules. It is hypothesized that resulting endothelial dysfunction and low-grade inflammation may lead to peripheral resistance, which contributes to hypertension. So in terms of possible interventions, intake of probiotic supplementations and functional foods has been associated with lower prevalence of hypertension. In a cross-sectional study using data from Enhanced, it was revealed that 21% reduction in the odds of developing hypertension followed yogurt or probiotic supplementation. Animal studies to date have shown some promising results. However, human studies are lacking, with few to date showing some degree of inconsistency. Data from the most recent systematic review, however, showed a mean decrease in systolic blood pressure of 3.31 millimeters mercury in hypertensive individuals. So in terms of mechanisms, as I mentioned, there are two main mechanisms that are identified, and the first one is the endothelial dysfunction. The effect of lipopolysaccharides on endothelial function has been examined through vascular activity studies and in animal models. And here you can see on the slide some of the main studies. A substantial impairment of vasodilation has been observed following lipopolysaccharide administration in mouse models. This was linked to decreased nitric oxide bioavailability paired with an increase in reactive oxygen species. Now, it is commonly accepted that nitric oxide bioavailability is strongly dependent on those oxidative molecules, as they lead to endothelial nitric oxide synthase uncoupling and ultimately deactivation. So inhibition of these molecules has been shown to restore nitric oxide levels and relaxation. And a similar effect was observed using TLR4 agonist, suggesting that nitric oxide bioavailability impairment is also mediated by TLR4. Furthermore, in the knockout model of TLR4 knockout model, the lipopolysaccharides had absolutely no effect on relaxation. And so overall, the collected data suggested a TLR4 mediated oxidative pathway activation following lipopolysaccharide exposure, leading to endothelial dysfunction as presented in this diagram. Now, for the second part of the mechanism, and that's vascular inflammation. A mechanism of lipopolysaccharide-induced vascular inflammation has been extensively examined in animal models and signal transduction studies. Lipopolysaccharide incubation resulted in a 10-fold increase in NF-kappa B protein and a 6-fold increase in interleukin-6 levels. In terms of human studies, an acute intravenous injection of lipopolysaccharides resulted in a high spike in E-selectin levels. Taken together, this data suggests TLR4-mediated inflammatory pathway activation following lipopolysaccharide exposure, as per this diagram. And here's the final diagram combining both of these pathways, the redox and kinase pathways, and their interactions suggested by some in vitro and in animal studies, which again are described in this slide. I understand that you'll all have access to this PDF, so you'll be able to see it in details. Right, in terms of strengths, the major strength of this methodology is the understanding of the pathophysiological mechanisms underlying hypertension. And as a result, clinicians will be able to assess relevant points of failure in a given individual, which allows for more targeted and potentially more effective intervention. Various methodological designs included provide valuable information from which to draw data. In vitro and ex vivo studies were able to identify the role of specific molecules. Studies using animal models were able to detect a mechanism implicated in the development of the disease. In terms of shortcomings, I have listed here some design limitations, mainly the lack of randomization and blinding description, which makes it impossible to determine if the potential bias in outcome assessment was adequately minimized. Probiotic intervention studies found that lipopolysaccharides were 70% higher and TLF4 levels were 8-fold higher in spontaneous hypertensive threats compared with age-matched normotensive controls. Probiotic interventions with durations between 2 and 8 weeks reduce endotoxemia while protecting endothelium-dependent muscle relaxation through downregulation of TLF4 and reactive oxygen species, which further supports the findings from mechanistic studies. Probiotic interventions also reduce blood pressure and vascular inflammation in various animal models as measured by interleukin-6 and adhesion molecules. In terms of human studies, overall, clinical trials revealed a decrease in serum interleukin-6 and VCAM1 following probiotic interventions. However, there were great differences in effect size observed. This may be due to probiotic strains under investigation. Human trials and systematic reviews examining the effect of probiotic supplementation on blood pressure showed mixed results, even when using the same methodology, which may be related to the hypertensive status. For example, a 4-week fermented milk capsule supplementation had no effect on blood pressure in normotensive and prehypertensive participants, but resulted in reduction of a huge 11.2 millimeters mercury in hypertensive sample. In fact, subgroup analysis based on health condition consistently showed a significant blood pressure lowering effect in hypertensive patients. And here is a final mechanism diagram again, but this time showing points in the mechanism on which probiotics exerted an effect. In intervention studies, similar concerns were noted in terms of randomization and blinding. Other major shortcomings was the lack of adequate compliance assessment, with only one study assessing fecal samples at the end of the experiment. That's also in order to determine the viability of the ingested probiotics. All systematic reviews were very high quality, and statistical heterogeneity in the majority of meta-analysis was very low, which suggests a clinical significance. In terms of clinical application, probiotic interventions lasting a minimum of 4 weeks might have a modest yet clinically relevant blood pressure lowering effect in hypertensive individuals. It has been noted that the observed systolic blood pressure decrease of between 2 to 3.3 millimeters mercury has been associated with a 10 to 22% reduction in cardiovascular mortality. However, the optimal source of probiotic consumption, dose and strain remains unclear. The generalizability of the findings has to be considered in light of study population. Tight inclusion and exclusion criteria may simply lead to stratification, which present a concern in terms of external validity. Exposed pathophysiological mechanisms such as chronic inflammation and oxidative stress have been associated with a myriad of other chronic conditions, and we've just again heard from my previous colleague. And in clinical trials, probiotic interventions have been shown to decrease interleukin-6, which is a commonly used prognostic and diagnostic marker for systemic inflammation. Based on these potentially anti-inflammatory properties, other dysfunction caused by interrelated systems such as detoxification, energy production, or communication could be considered as targets for probiotic interventions. The implication of this research in terms of ethics in clinical practice should also be considered, particularly as it relates to autonomy. Explanation of underlying mechanisms could yield immense benefits in terms of motivation and willingness to comply, which has been problematic in the longer duration studies. While safety of probiotics has been well established across various studies, the absence of adequate regulations regarding commercially available probiotic supplements should be also considered. Probiotic interventions have been the sole focus of this review. However, other compounds such as berberine, curcumin, chlorogenic acid, Elsevier, have been shown to inhibit lipopolysaccharide and TLR4 signaling pathway, and so may potentially confer antihypertensive effects. While there has been some attempt to identify pathophysiological mechanism underlying antihypertensive effect of probiotics through exploration of inflammatory biomarkers such as interleukin-6, an extension of the research methods to nitric oxide serum levels and reactive oxygen species would provide evidence for the potential impact of probiotics on endothelial dysfunction. It is also noteworthy that none of the studies evaluated specific bacterial deficiencies at baseline. The efficacy of probiotics might therefore be enhanced if the strains were customized to address specific imbalances, providing a more targeted approach. And finally, further mechanism reviews should be performed to understand the components of other processes implicated in hypertension and related nutritional interventions. Taken together, these methodologies could be expanded and provide data sets for statistical machine learning models. Such models could infer relationships between relevant biomarkers and candidate interventions in order to predict the most beneficial set of nutritional recommendations and, as a consequence, a more personalized care. Thank you very much. Hope that was useful.
Really interesting. Thank you so much.
Thank you.